Hello, my name is Dr. Zubair Karim. I'm a neurologist in Massachusetts. I start this video with greeting of peace and happiness. I'm going to talk about some neurological conditions, and the reason I'm doing this, over the years I've been a neurologist for almost 25 years now. I have learned that there is an acute, significant shortage of neurologists. In fact, I live in Massachusetts, and Massachusetts has the highest number of neurologists and, in fact, all physicians per capita in the United States. I haven't looked at it, but if that is true, then Massachusetts probably has the highest number of neurologists per capita all over the world, because we have more physicians per capita than other places. Even then, there is a significant wait in our office. For appointments, people have to wait weeks and weeks, in some places for months. That means that other places have even bigger problem. So actually not everybody who has a neurological symptom or condition needs to see a neurologist, but apparently a lot of people are looking for neurological consultation. And also when I see patients in my office, I provide diagnosis and options for treatment and management, and also educate them. I thought some of that I could do differently. I could provide patients an opportunity to learn about their conditions in a different way. Nowadays, more and more people are really watching videos. Instead of reading, sometimes watching video is a better option. So this is an effort in that direction to see if I could talk about certain neurological conditions, and patients can watch this video and learn about it instead of making an appointment with a neurologist to know about their conditions. Now, before I start this session, I have to make a few disclaimers. The first one is that this video is intended for patients. It is not really for neurologists, and not also for doctors, but I see that when I was looking at what I'm going to talk about, it could be useful for training doctors and general physicians and nurses, but primarily it is really for patients who may not have direct knowledge of medicine. Also, the purpose of this video and the other videos I would record is not to make formal diagnosis. To make a formal diagnosis and treatment recommendations, for that, one has to see the patient themselves in person, evaluate them, and many other things before reaching a conclusion of diagnosis and treatment. So it is purely for patient education. Hopefully, patient would know their condition or symptoms better and would make better decisions. Next disclaimer is that I have no relationship with any pharmaceutical company or any hospital for that matter. I mean, my practice is associated with the hospital, but I don't have any other relationship with any pharmaceutical company. So anything I'm going to talk about, I don't have any direct financial interest in it or any relationship of any kind. So I'm making no claims about that. Also, finally, I'm also not looking for, the purpose of making this video is not to look for more business. There is already quite a significant wait, and that's really the purpose of making this. And it seems like that a lot of people who would watch this video might watch this video. They would not be in my area, and they really can't really see me. So that's really also not an issue. So I have no disclaimers, technically speaking. So while I'm doing this, after this initial introduction, I picked up a topic which is very relevant to neurology. I was just thinking that I've been practicing neurology in office setting for about 20 years. I don't think I can remember a single day when my schedule did not have a patient with headache. Every day there are patients, one patient or many patients, who come with symptom of headache. So headache is so common and so important to talk about, so that's why I picked up this topic first. Headaches are very common, and headaches are known to human beings, and human beings have been talking and recording about headaches for centuries. Headache is just a symptom, of course. Patients tend to differentiate between what they call headache or head pain. For example, you could bang your head and you have a head pain maybe. That may or may not lead to headaches. Headaches per se is most common understanding of headache is like migraine. So I am going to primarily talk about headaches. Now, this first video I'm going to make is going to be for migraine. There are many variety of headaches, migraine being the most common type of headache. So this is going to be that video. Hopefully, I would make other videos. I have thought about making a video about cluster headaches, another one for menstrual migraine, and maybe trigeminal neuralgia. Those would be separate. But this one is primarily for migraine headaches. Now, let's briefly talk about migraine. I must tell you that when a patient comes in my office and I diagnose patients with migraine or headaches, I really give them this overview in few minutes. But it is because there are patients, one patient after another, so many patients with a headache that sometimes it is difficult to do and gets boring also. So sometimes it feels like if there was a switch, I could turn it on and patient could just watch that introduction. So this is really, this might help, that providing an overview patient could watch at their home, in their home. Migraine. Migraine is the most common type of headaches affecting human beings all across the world. Generally speaking, about 8 to 10% of men and about 16 to 20% of women have migraine. If you think about it, that's a huge number. Population of my state is about 8 million. That means significant number of people of headaches. If out of 8 million, about 4 million of women, about 20% of those, that is a significant number of people who might have headaches. But the fact is that the most people, or at least majority of people who have migraines, they don't really seek any medical attention. They are not really formally defined or diagnosed with migraine. In their mind, they just have regular headaches. They just either don't take any medicine or they just take some over-the-counter medicine, and they call them so-called regular headaches. I sometimes joke there is no regularity about headaches. Every headache is irregular. But about 50% of patients, maybe, they are not formally diagnosed. Out of those who are diagnosed or come to see their doctors for headaches, not all of them go and see a neurologist. And I must say that not everyone needs to be seen by a neurologist. The purpose of this video really is to decrease that burden and to see if patients could understand their condition and discuss with their primary care physicians and figure out a plan of management of their headaches with the help of their primary care physicians. Why people get migraine? Migraine is something that patients are, or people are born with. The cause of migraine is likely genetic, though we have not been able to figure out the right gene for migraines, at least for most of the migraine. Only a fraction of migraine genes or a genetic basis is known. Most of it is not known. Probably it has multiple genes are involved and then environmental factors, but likely it is a genetic disorder. Now, what exactly that means, genetic disorder? It means that there is some genetic basis of migraine that results in changes in one area of the brain, especially the brainstem area, where it seems like the trigger for migraine is, and from there many chemical and electrical changes happen leading to migraine. But if we try to look at that area by doing an MRI, we don't really see anything abnormal. How do we know that that area is involved? Because there is a special technique of MRI called functional MRI, and that can help, but those MRIs are not used in clinical setting because there is no real benefit of doing that kind of testing, which is more involved and more expensive. Regular MRIs and CAT scan don't really reveal any abnormality about migraine. What happens in migraine? For that, I would ask you to imagine that brain is a circuitry. It's a complex web of cells that create extensions which are like bunch of electrical connections, and it's running on low voltage, and the transmission in brain is both electrical and chemical combination of that. When migraine starts, this trigger in the brain, it leads to a sort of electrical depression, if we could call that, and in fact that's what we call it, electrical depression, that travels from front to back relatively slowly. Usually electricity spreads quickly, but this is a kind of wave of electrical depression. It's like a wave slowly coming forward of electrical depression. In some patients it's more noticeable than others, and in patients where it is more noticeable, they have more aura type symptoms. That electrical depression, ultimately it also leads to some dilatation or widening of some arteries, and from there it leads to changes in the nerve ending that are around the arteries and close to arteries, and also some special areas of and special nerves, for example trigeminal nerve and some other nerve areas in outside the brain, inside the skull, and that leads to some releases of chemicals and neurotransmitters, and that also leads to a kind of inflammatory response, and all this for patient is pain, but many other symptoms. Now, that's very briefly, and because what we call pathophysiology or the physiology of migraine is much more complex, and that's really not the topic of this video. That would be more at physician level, or entirely different topic even for everybody. So I would just say that that's what it is, from electrical depression to dilatation of blood vessels to changes in nerve endings leading to release of chemicals and mild inflammation leading to pain and many other symptoms. What are the symptoms of migraine? First, most people who have migraine, they do not have any what we call an aura, meaning there is no warning of other than just a mild headache. Mild headache is warning for more headache. But there are few patients, we would say about 5% or less patients in migraine, who have a distinct set of symptoms we call aura. And those migraines we call migraine with aura. Aura is a set of symptoms which are not pain. These are non-pain symptoms of migraine. Most common form of aura is visual changes. And what is that? Patient could see a bright light something bright or something colorful. And it is usually a bizarre type of shape or shining shape with sometimes multiple edges. And classically, it seems to get bigger and bigger and bigger, or larger and larger. And so, because it is flashy, it also makes vision blurred. So patient would have blurred vision with that. That's more common migraine aura, we call visual aura. Some patients have different sort of aura that we could call body aura or somatic aura, which is either numbness or weakness type of feeling. That is also fascinating and classical of migraine. And for example, the most common would be the patients might feel a numb feeling either in hand or shoulder, an uncomfortable or numb feeling. It's not really a pain. It's either numbness or Novocaine type of feeling or an odd feeling. And then it seems to spread slowly in a matter of minutes. It's not like stroke. Stroke would typically present in a second or two, but this migraine symptom, which has some feeling of stroke-like symptoms, it would spread slowly in a matter of few minutes, either from here to there or here to here or even face, usually on one side. It could cross the other side. And it typically lasts for 5 to 60 minutes and then slowly go away. During that time, it can also go to leg. It can also make that arm or leg clumsy or weak temporarily. And sometimes this could also lead to visual symptoms, but usually they are separate. That's body aura. Third type of aura is what we call brainstem aura. Now, brainstem means that the stem, the deep part of the brain, this is the top of the brain, and then middle of the brain, and the brainstem is the deep base of the brain. Brainstem aura is a little bit different. Those patients present with symptoms of, let's say, unsteadiness before migraine, sometimes with migraine. Unsteadiness like they're drunk. When they're walking, they're like drunk. The vision is blurred. They could have double vision, nauseous, and they could speak like they're drunk. So those symptoms, they could also last a few minutes to an hour or two, sometimes even longer. That's brainstem aura. All these auras, patients who have migraine with aura, usually they are followed by a headache. Headache could be on the same side of where the aura is or the other side of the whole head. But sometimes they have no pain. And sometimes the pain is relatively mild and they don't really talk about pain. They're really talking about the rest of the affairs. But sometimes pain could be quite significant. And headache could last for an hour or a few hours, and then it goes away until the next attack comes. So that's migraine with aura. Remember that migraine with aura is a rare form of migraine, relatively rare, much more common, and the most common variety of migraine is what we call migraine without aura. That would be migraine without what I described a few minutes ago, all the auras. Migraine with aura typically starts with a pain somewhere, like a ache here or ache in the eye or forehead. Remember, pain of migraine could be anywhere. It could be on one side or both sides. It could be in front or back or side or temple or eye or face or ears or neck or shoulders. It could start anywhere. It may stay on one side, it might go to the other side, it might stay in front or back. Sometimes you might have in front and the other day you have it in the back, or one day you have on one side and the other day you have on the other side. So migraine pain has no set pattern. Also, migraine pain could be so mild that you might think it is just that I'm just not feeling well for some reason, or you don't have to do anything about that pain. Or it could be so significant that it could be disabling. So there are a variety of variation of severity of migraine pain. It could be completely debilitating and and severe. In fact, people, I won't call patients, people who never had a migraine, a real migraine, they have no clue what a migraine is. If one of the partners in a relationship has a migraine and the other one never had one, he or she does not know that what exactly happens to the other person. Migraine is could be a terrible pain and terrible condition when it happens. So it is very good to educate yourself what it could be. It could be severe pain. Pain of migraine, I talked about how frequent migraine pain could be. Well, there are patients who get maybe one migraine in few years. If you talk to them, they say, I don't get any migraine, I just had one few years ago. Or it could be once a year, or once a month, once a week, or once a day, even more than one a day. So there are a variety of patients who are migraine. Now, to explain why this happens, I use this description just for patient education. It may not have so far solid basis in our understanding of migraine, but this is the way I explain to patients. Patients who have migraine, they are born with a slight abnormality in one part of the brain that I call migraine switch. So when I say migraine is genetic, what I'm trying to say is that a patient with migraine has inherited that migraine switch. If you don't have a migraine switch, you're not going to get a migraine. You might have a headache if you have infection or you hit your head for a while, but you're not going to go into migraine. Migraine is a headache after headache after headache that keeps on coming. You're not going to go into that because you don't have that migraine switch. Now, if you do have that migraine switch, if you're born with that migraine switch, then switch could be quite stable that only rarely it would turn on, or it could be so touchy that it's turning on every day. It's like a malfunctioning switch. So anything would turn it on. If your mood is a little off, you're stressed, it is on. If your hormones are a little up and down, it is on. You have a little cold or flu, it is on. You didn't sleep well, it is on. You're exposed to cheese or chocolate, it is on. So there are patients whose switch is particularly sensitive, but not everybody has that sensitive switch. In spite of having that switch could be quite stable. We don't really have good understanding so far why that is so, because technologically we are not advanced yet. We need to find a way to image brainstem in so much clarity in these patients that we may be able to differentiate whose switch is sensitive and whose is not, but we're not there yet. Now, we talked about frequency of migraine. Now the next question is severity. I already talked about the mild to severe and disabling. Next is the type of pain. How do patients describe their migraine? What is the type of pain? Some would call it a pressure type, stabbing type, pulsating type, throbbing type. They're all variety. You could have combination of all. So sometimes it seems like that something is burning inside, or something is trying to come out of the head, and all those variations. Sometimes it's just dull, boring pain. All kind of type of pain can be described by patients with migraine. Usually when patients have migraine, their headache is worse with doing certain things. For example, if you're having a migraine and if you're physically active, up and about and running, jogging, or exercising, it feels like the headache is getting worse. Exercise is not really triggering migraine, but it is making it worse. Similarly, looking at bright light, I have two lights in front of me right now for this video, and this kind of light can also make migraine worse. noisy places can make migraine worse. Uh, Also, certain foods can make migraine worse. While you're having migraine, I already stated that chocolate and cheese, some people are sensitive to banana, some to avocado. You have to, in terms of exposure to food or trigger for food, I would suggest you do your own experiment, because not everybody is sensitive to food material. So what you do is, next time you eat cheese or slice of pizza or blue cheese, then make a note of that. Did you have a migraine after a few hours? And if you did, then you would know it. You would make note of that, and next time you would be careful, either not eating or taking appropriate precautions or medicine around it. So if you're not sensitive to cheese, then you can eat cheese. If you're not sensitive to chocolate, sure, you can have chocolate. But so not everybody is sensitive to that. What makes migraine somewhat better when you have a headache? Patients universally say that going to a dark, quiet room helps. Resting, putting your head on the pillow helps. Sometimes putting a pillow on top of head helps. I haven't talked about treatment yet. Before I go there, I would also talk about another phenomena we call prodromal symptoms of migraine. What does that mean? It means that patients who have migraine, they sometimes have symptoms before migraine, meaning before the pain starts, and many symptoms after pain is gone or treated. So especially after. So what are those symptoms? Patient could still feel uneasy, unsteady, somewhat foggy, confused, somewhat nauseous. These symptoms that could continue for many hours, even for a day sometime, they are known and they are called prodromal symptoms of migraine. Another symptom that patients could feel is sensitivity of skin, which is that even touching, women would come and say they cannot comb their hair because every time they put a comb, it hurts on the head. That's classical of migraine. It's nothing significant. It ultimately goes away. That could happen during migraine or during prodrome of migraine. Also, be aware that if I didn't mention, I don't think I mentioned it before, that migraine pain can be confused with sinus pain. That is probably the most common misunderstanding. A lot of patients who have migraine pain right here or in this area, they and their doctors might think that this is sinus condition. They might call their doctor and say, I think I am having sinus problem and I need my antibiotic. And they might take a course of antibiotic and yet another course of antibiotic, but that kind of headache keeps on coming. That's really not sinus problem. That is, of course, you can have associated sinus problem. What I'm trying to say is that sinus symptoms are very commonly mistaken. Let me put it the other way. Migraine that affects this part of the face is commonly mistaken as sinus condition and treated as sinus condition. That is also migraine. It's just that the pain is right here in front and face, because the nerve that goes here, those nerve endings are triggering migraine or activated in that patient's migraine. So some patients have migraine where pain is predominantly in front. Some patients have migraine when the pain is predominantly on the side. And some patients who have migraine predominantly in the back, especially patients who have we call brainstem migraine, they are in the back. Be aware of that, this sinus issue, and don't over-treat yourself with antibiotics, because that may not work. If it keeps on coming, you should consider migraine or treatment of migraine. Now, after that introduction of migraine, let's see, who are the patients who would need treatment? Well, migraine being so common, treatment option is not available across the globe for everyone. We in the US, everybody who has a headache, he or she might think that I need to see a neurologist. I sometimes make a joke about that, if there is no neurologist in a town, nobody really need to see him or her. But if there is one, everybody needs to see a neurologist. The reason for that is we as human beings, we are running on electrical system. Our neurological system is electrical system, electrico-chemical system. It creates a number of symptoms every day, really. Sometimes it's of numbness, and sometimes of a little bit weakness, sometimes of pain. All these are neurological symptoms, but most of the time they are benign symptoms. They don't need any real attention or medical attention. So, but sometimes what happens that if there is free availability or easy availability of neurology, then neurology consultations seem to increase tremendously. But I must say, most of the people with headaches or migraine, they don't need to see a neurologist. Now, about treatment. As I stated, migraine is a condition that has been affecting human beings for centuries, so we have been documenting headache and what we as a human being can do about migraine. So there is reasonable historical evidence how, for example, Egyptians treated headache, what Hippocrates suggested or talked about headaches. In fact, some of the description is exactly the same. The symptoms that were described then, we're still seeing them. It's the same human being in the same condition. So that also tells us that we have centuries of experience dealing with this condition. I hesitate to call it a disease. Migraine is a condition. Now, let's talk a little bit about history. What we have done as a human being. Interestingly, we have tried everything you could imagine to treat headaches. All cruel or non-cruel means have been tried. Imagine some young person coming, and usually migraines patients are young, coming that I have this pain, it's like something is trying to come out of the head. So historically we have tried to take that thing out of the head, making holes and bloodletting and leeches and you name it, and all kind of things. Fast forward, what people are doing now with migraine, other than just taking, if any medicine is available, there is something I call pressure massage. For example, I remember my mom had migraines when I was young. When she would have a headache, she would lay down and she would ask me to do this. She would lay down with eyes closed, and I was just doing this. Kind of, I would call it pressure massage. Whatever you want to call it is fine. I'm just not squeezing too hard, just a little bit, 4, 5, 10 minutes. She didn't take any medicine. After a few minutes, she would go to sleep. And sleep, a lot of time, can turn the migraine switch off. Sleep has this tendency to turn the migraine switch off, but not in every patient. And then she would be fine. That is one benign way. And there is a variation of that theme in different cultures. In Chinese culture, they call it tuna therapy, but it's the same theme. I would say in South American cultures, women might wear a tight bandana around their head if they're having a headache. Same concept somehow. There is actually physiological mechanism about this, or physiological understanding. When we are creating a different sensation on the head, we are bypassing sensory pathways, and the pain of migraine to patient becomes less when creating an alternate sensation. So there is physiological basis of that, and that is totally benign, and anybody can use it. Of course, it would work for acute intervention if somebody is having a headache, and it could be used just alone, or it could be used with other treatments. Now, How about something like acupuncture? Yeah, acupuncture can also help with acute migraine. It might help, not in every case, but just like the previous treatment I described, it can also help. But there are limitations of acupuncture. Acupuncture is not a fix either, meaning it can turn off the migraine switch maybe, but temporarily. So next time migraine comes, the switch is again on. Acupuncture does not completely fix migraine. Actually, nothing we have that fixes migraine completely. But acupuncture could be used. Why it is not commonly used in US and many other places? Because of logistics and money involved. For acupuncture, you have to, every time you have a headache, you have to go and sit and lay there for an hour, or sit or lay there for an hour or so, have those needles. That's fine. Sometimes it is useful, but most insurances don't cover this. It is an expensive thing. You have to go out. So there are logistical and financial issues with acupuncture, but it could be used. For example, it could be a useful option for women with pregnancy and migraine if they could afford it. A few sessions. Typically, they do it once a day for a few days. How about natural treatment, so-called what we call natural treatment? I must tell you that over the years, I have tried many things, and I have looked at some trial data also, formal trial data. Natural things like magnesium, like riboflavin, like feverfew, and similar things. They are not extremely effective. Coenzyme Q10, they are not extremely effective. In fact, there is a preparation available in our area which is combination of some of that. That also is not extremely effective. There is no harm trying it other than the money you are paying. But I would suggest if you are trying any of this, try it for, or any controlling medicine for migraine, try it for maybe a couple of months. If it helps, it helps. If it doesn't, then no reason to keep on taking it. Also, none of the natural stuff is really that effective for acute treatment, meaning when you are having a headache. It is not very effective for that. Now, if that also has not worked, then we go to some formal ways of treating migraine. In formal ways, first I will talk about over-the-counter medicines. Now, just for explanation's sake, let's figure out a system of scale so that you could understand. Scale of 1 to 5 of these medicines. So 1 to 5 means in terms of safety and their effectiveness or efficacy. 1 being just barely effective and 5 being fully effective, meaning every time you would take a medicine that is category 5, it would always work. So 1 to 5. And safety, 1 means that drug is completely safe, and 5 is that it is dangerous or it has significant side effects. Dangerous things we don't prescribe, but significant side effects. And so 1 to 5. So let's look at different things. Of course, the head massage is completely safe. Bandana is completely safe. So going to sleep and taking care of headache is completely safe. So, and if it works, it's fine. But in efficacy-wise, it's medium. It doesn't work that well. Now, as far as natural products are concerned, efficacy-wise, I would say they are even less than 1, 0.5 maybe. Safety-wise, yes, they are generally very safe. But effectiveness is marginal. Now let's look at over-the-counter medicine. In over-the-counter medicine, let's look at the safest one first for pain, which is acetaminophen or Tylenol. In our place, the brand name is Tylenol. The real drug is acetaminophen. In many other places, it's called Panadol, but it's acetaminophen. It is reasonably safe, though up to a limited amount, meaning it doesn't bother your stomach, but if you take too much of it, it can bother your liver. So it has risk. But in terms of efficacy for headaches, it is really maybe about 1. I won't go beyond that. It seldom works, but in some patients it works, and effectiveness is just 1. For a mild headache, it might work. If you have to try, you can try 500 milligram acetaminophen. You can take it empty stomach. You don't have to, but you can. It would not bother you. Generally, it won't bother your stomach. So don't take more than 4 of those in a single day. After that, it becomes somewhat risky for your liver. Now, obviously, all these things you would discuss with your primary care physician if there is more concern about what medicine you need to take or not take. I'm providing education only. You would discuss that based upon your particular situation. You might have a condition where none of this could be taken, or some of that might not be taken. So be aware of that. Next is aspirin. Aspirin, interestingly, historically was a game changer. Came from willow tree and ultimately was synthesized. Aspirin, in terms of efficacy, I would say it's more than Tylenol. I would take it to about 2 out of 5. Not 5 out of 5, 2 out of 5. Just FYI, is there any medicine we have that is on efficacy scale 5 out of 5, meaning it would work every time you take it? No, we do not have one. So let's just be clear. So aspirin is about 2. But aspirin has its own risk. It's an acid, it can affect your stomach. And depending how much you take, it could create other issues. But if you take it with food, and if you don't have any other medical issues, and no bleeding disorder either, you can take a couple of aspirins. Each aspirin usually is 325 milligram. Smaller doses of aspirin, in US it's called baby aspirin, or 81 milligram, and in Europe it also comes in, I think, 43 or 45 milligram. That's separate. They are not designed for pain. Their purpose is different. For pain, the minimum dose is, at least for adults, 325 milligram, 1 or 2 pills with food. You can try that. If that works for you, fine. Now, next is ibuprofen. Ibuprofen, naproxen, and similar medicines. Ibuprofen and naproxen, they come in different names in different countries. Even in US, they come in so many different names. But if you read in what is inside, it's either ibuprofen or naproxen. I don't want to go into brand names, but they are in that category. They are all over-the-counter medicines. Now, you can take 1 pill. Ibuprofen, you can take each one in US, it is 200 milligram. You can take 1, may not work. You might take 2 or 3 with food. Their effect and risk is very similar to aspirin. So in terms of efficacy, they are about 2. In terms of risk, as good or bad as aspirin. So be aware, they could affect your stomach, could cause gastric irritation. If you take too much, it could be harmful to your kidneys too. And aspirin and naproxen and ibuprofen, they could also raise your blood pressure. Be aware of that. Tylenol does not, but these can. So that was over-the-counter medicine. Now, in over-the-counter medicine, the next level now is combination of medicines. What if you take an aspirin and take something else with it? So there is actually a combination available, which is Tylenol and aspirin and a little bit caffeine. And that is your Excedrin migraine. So companies, what they have done is they put a word migraine, but if you read closely, what is Excedrin migraine, which is basically Tylenol, aspirin, and caffeine. what is Advil migraine, which is really ibuprofen and caffeine, something like that. So they have added a little bit of caffeine. So maybe this is the time to talk about caffeine briefly here. Caffeine has an interesting relationship with human beings. In my opinion, headache probably is one of the causes of introduction of caffeine type of things to human being, because caffeine is mildly effective for headaches, and headaches being so common, it probably worked initially when there was nothing available and people thought that this has some medicinal value. In fact, I can tell you that my grandmother used to say, make tea only when she was sick. So people, that generation had that understanding of tea. But caffeine has a complicated relationship. If you do not drink caffeine at all and you have migraine, I'm not asking you to start drinking caffeine, that's your personal choice. What I'm saying is a little bit of caffeine might help with headache, especially in combination of other medicines, especially combination of Tylenol and aspirin and caffeine can help. One pill of Tylenol, or I'm using Tylenol, I should say acetaminophen, so that people who do not know what Tylenol is can understand. Acetaminophen 500 milligram, aspirin 325 milligram, and a cup of tea or coffee. Excellent combination for a migraine treatment. Efficacy could be about 2.5, I would say, 2 to 2.5. Risks I already talked about other than caffeine. What is the risk of caffeine? Too much caffeine can make you a little bit jittery. If you're not into caffeine, it can create a little bit of heart racing, palpitation feeling if you're not into caffeine. And if you are into caffeine, for example, let's say you drink a cup of tea or cup of coffee every day, then you might benefit from one extra one, but don't overdo it, because overdoing caffeine, meaning if you take 2 cups of coffee every day and one day you take 4, you might have a headache. So that's another paradoxical effect of caffeine, that too much caffeine also causes a headache. At the same time, be aware that if you take a cup of tea or coffee every day and one day you don't do that, you're going to have a withdrawal headache. There is caffeine withdrawal headache. Withdrawal headache can happen from any medicine that could be used for pain and migraine. Caffeine is being one of them, so it has a withdrawal effect. You can have a headache. That headache could last 2-3 days, and after that it goes away, but caffeine can cause withdrawal headache too. So those are combination of things, and one could use combination of things by its own or by combination if it is available. What if that also does not work? Now those are the patients who then go and see their doctor to say that I have tried all those things and nothing works. Then the doctors typically, after making the diagnosis, what they do is they first try prescription strength ibuprofen, naproxen type of medicines, which is a stronger of same kind. And there are many. I would say again, naproxen prescription strength, instead of 200 milligram, trying 500 milligram. Ibuprofen, instead of trying 200 milligram, trying 800 milligram. Of course, aspirin is over the counter, but taking more than 2 pills of aspirin is not recommended. You should not go beyond that at one time. That would be more harmful. Also, all these so-called aspirin type of medicine, we call them non-steroidal anti-inflammatory drugs. That's a class of medicine. They all, because they could affect your stomach, so you should not take them empty stomach. Put something in the stomach, or if you have to take them on a regular basis, take something with it, a medicine with it to protect your stomach, like Pepcid or similar medicine. Now, if that also does not work, then we go to next set of medicines. And there, for migraine, there we talk about a group of medicine we call triptans, Triptans, triptans. Triptans started, I believe, in early 80s or mid 80s, if I'm not mistaken, with the first introduction of sumatriptan or Imitrex. When it came out, some people thought it was magic. No pill has worked like that before. It was a so-called designer medicine. By that I mean that instead of just hit and trial, scientists looked at mechanism of migraine and tried to design something that could change something in that mechanism of migraine, and that was the sumatriptan. The discussion what that is, that's a I think it's a different subject, would require different discussion. But in any case, this class of medicine are effective to treat migraine pain, but no other pain. You could have pain anywhere in your body from any other cause, or even your head pain. For example, if I hit my head somewhere and I have a laceration and this is hurting, taking triptan is not going to help. Triptan only helps with migraine. And again, going back to that concept of migraine switch, that what triptans do is they go in and turn the migraine switch off. They can't really turn off any other pain switch. They just turn the migraine switch off. So sumatriptan or Imitrex, it comes in different names in different countries now because it is an old medicine, but sumatriptan still is widely available. This family has many other members now over the years. I don't think any new member has come for many years. Sumatriptan, almotriptan, froatriptan, rizatriptan, naratriptan, alitriptan, you name it. There are many. Which one is more effective or most effective? That is a difficult question, because what happens, there is a business side to medicine too, that comparative studies are many times not available, so it is difficult to say. The only thing is that one medicine might be more effective for one patient and not for others because of the difference in biology. What we are missing at this point, this is 2019, and hopefully we might be there in some 20 years or so, or maybe longer. If you look at medicine, for example, if I want to prescribe triptan to one of my patients with migraine, I do not know which one of this would be most effective. And that would depend upon the genetic makeup of that patient. That information we do not have yet. The work is in progress right now to understand the genetic basis of people, especially in relationship to their response to medicines. That work is being done and slowly would be available to us maybe in a couple of decades. And then we would be able to figure out exactly or narrow it down that this one of the triptans would work better for you and the other one might not work. But other than just trying, we don't have any other way now. So the triptans are pretty good medicine for migraine. In terms of efficacy now, I told you that natural products were about 0.5, Tylenol was about 1, aspirin, ibuprofen type of medicines were about 1.5 and 2, and combination of medicines were about 2, maybe 2.5. Triptans are above that. Efficacy of triptans in general, I would say, is about 3 to 4. Sometime even beyond 4. I already told you there is no category 5 medicine, meaning we don't have any medicine that would work for every patient every time. We don't have any. So triptans are most effective medicines to treat pain of migraine. It is not designed to treat each and every symptom. It is primarily designed to treat the pain. Now, triptans are generally safe unless they are not recommended for people who have heart disease, especially ischemic heart disease, coronary heart disease. It is contraindicated. In fact, that was a problem when sumatriptan initially came. And after we learned that and we stopped doing that, we don't have any more trouble with that. So to this day, these medicines are not recommended for patients who have documented heart disease. Or I would say, is there any other obvious contraindication? Obviously, uncontrolled blood pressure is a contraindication to these medicines. Generally, they are safe, but there could be some other contraindications relevant to individual patients, but those were too general, that heart disease and uncontrolled high blood pressure. Now, what could be the side effects? These medicines can have side effects, so I'll tell you what are the more common side effects? The joke about side effect is sometimes I even think that way. I'm in that age when obviously I also need medicine sometime. If you start reading, nowadays information is freely available. It was available before, but just not to everyone. Now it is available to everyone. Anybody can just type what are the side effects of any medicine and the whole list is in front of you. If I read side effects of Tylenol, you don't feel like taking it. It could kill you, of course. But the thing is, you drive an automobile and you can have an accident and that could kill you, but we still drive. In life, we take calculated risk. And I would suggest you also take calculated risk. You weigh which evil, the evil of migraine pain or evil associated with medicine, which evil is bigger, and pick up the lesser evil. That is a decision you have to make with help of your physician to help you understand the risk of medicine and treatments. That's what we do, generally speaking. Now, what are the side effects? If you take any of the triptans, what could happen is that it makes you lethargic. It's like you're losing your soul or something. Not every time, but in some patients it is more than others. But that's a common feeling after taking triptans. Secondly, it could create chest pressure and neck pressure and like swallowing difficulty feeling. It's like you're having a heart attack. But actually that is really not because of heart. That's a peculiar side effect of these medicines. It is not a contraindication. If you don't have any heart disease, that's not a contraindication to take this. Meaning you can still take it. If your heart is okay and you're having these side effects, you can still take it safely. But be aware that it could create this feeling of chest pressure and palpitation. Some patients, based upon a variety of patients, some people absolutely don't like that. Okay, then go to a different medicine. But that could be a side effect. Also, sometime after taking it, instead of making headache better, it could make headache worse. That sometime happens. It is difficult to say if the headache was just going to get worse on its own and medicine didn't work, or the medicine made it worse. That is a difficult question. In terms of how do we pick up which triptan to give, that decision, especially in US, for example, where most of the patients do not pay from their own pocket. The decision ultimately boils down to what their insurance companies dictate. Unfortunately, that's not in doctor's hand. In my office and in my practice, when I look at any medicine, I have multiple factors. First of all, I want to know which medicine is the most effective, could be the most effective medicine, which group of medicine could be the most effective for my patient. Second thing would be, after effectiveness, which one of those is the safest one? And the third decision I have to make is which one of that is the cheapest one. We all physicians do think about that way, and we have to, even as a society, because multiple medicines sometimes are available. There is really no or marginal difference between them, and some of them are very cheap and some of them are very expensive. There is really no need to spend more resources when you can just use a cheaper version. So we all make that decision, and insurance companies also make similar decision based upon these factors and sometimes economical factors. And they have this system that if somebody has a migraine and if we want to prescribe a triptan, it's going to be this one first and that one first and then. But I have learned over the years that some, like I told you before, some triptans work better in some patients than others. So there is no harm trying a different one if one doesn't work. Next one is after triptans, there is another class of medicine we call ergots, E-R-G-O-T-S, ergots. Not many are available nowadays. In fact, one of the nasal sprays available, dihydroergotamine nasal spray is available. I rarely use this because in efficacy scale, it is as good as triptans. It is 3 to 4. But in terms of risk, it is slightly larger than triptans. So that's why I would rather stick with triptans unless they don't work. For migraine treatment, and before I go there, I have to tell you that triptans are the class of medicine in general that are available in multiple forms. They're available as pills, they're available as sprays, not all of them, but at least some of them. They're available as pills, sprays, and injection. For example, sumatriptan or Imitrex, it comes as a pill, 50 or 20, 25 to 50 to 100 milligram. 25 milligram for adults really don't work, so if you have to try in an adult, try 50 milligram. It's available as a pill, and then it's available as a nasal spray, and it's also available as an injection. In terms of what is the difference? Well, the side effect is same in all of them. The real difference is the speed of action. If you take a pill, it might take an hour or two to kick in, if it's going to work. If you take a nasal spray, it would take about 15 to 30 minutes to kick in. And if you take an injection, it might work in 5 to 10 minutes. So depending where we are and which one we want to use, also depends upon the price, by the way. Pills, of course, are cheapest, but be aware that triptans are not cheap medicines. They are not cheap as aspirin or Tylenol. In every society, they are pretty expensive. Here they are also in US quite expensive. But in terms of these three, pills, spray, or injection, pills are cheaper. Spray is more expensive and injections are most expensive. That's why most insurances, what they do is they would prescribe, if you want to prescribe pills, they would say, okay, you can have 8 to 10 pills a month, and if injection, couple of injections a month, and if sprays, maybe four sprays in a month. There are other reasons that we doctors and insurances restrict these medicines to not more than 8 to 10, and I'll talk about that a little bit later. But there are other reasons, medical reasons. Now, do we prescribe opiates type of medicine? That's another class of medicine. Opiates like morphine type of medicines for migraine? Not really. In terms of efficacy, their efficacy is not different from ibuprofen and naproxen type of medicine, so they are available. So, and their risk is significant. The risk of habit forming is significant. Migraine is not a condition that would go away in a few days or a few weeks. It's a lifelong thing. So you don't want to expose somebody to a medicine where they have to take that medicine and you might create another problem. That said, are there some patients who are not, are there any patients who are treated with opiates? Yes, but generally speaking, opiates are not prescribed for these reasons, because they are not more effective than non-steroidal anti-inflammatory agents, and number two, they are more risky compared to others. Now, what if we have tried all this and all of this has not worked? What if all this has not worked? What do we do? Obviously, a lot of patients show up in emergency room, get frustrated, waiting outside for many hours, many times, and then they go in and get IV fluid and some other injections, and that come home after a lot of frustration and waiting. That is not a pleasant experience, but sometimes unavoidable. But what else we could do? I'm going to provide you general guidance so that you are aware that some other things could be done. There are some combinations we can use as outpatient, and you can also try with the help of your physicians to try those combinations. For example, you can combine triptans with a medicine which is for nausea. See, in many patients, nausea is a significant problem. Nausea and vomiting is a significant problem with migraine. But triptans don't really have an effect on nausea. So if you combine a nausea medicine with triptan, that combination makes it much more effective. And that would be a good example would be, let's say, metoclopramide as a nausea medicine. These two medicines combined, they both are prescription medicine, but your physician can prescribe it. And that combination would work much better. And then combination of triptans and ibuprofen or naproxen type of medicine also make it more effective. In fact, a few years ago, a company came out with a combination drug with the naproxen and sumatriptan and made it much more expensive than what you can just simply buy otherwise, these two things. So what I would say is try to combine triptan, like sumatriptan, with an ibuprofen, or triptan with a metoclopramide, or all three together. That is also a combination. Sometimes that could work. I sometimes call these cocktails of medicines, but be aware when you're taking those, take it with food, and lay down and don't drive, and be safe if you do that. I sometimes even, because I told you the triptans create a feeling of lethargy, to counter that I also tell them to drink a cup of tea with it. So a good cocktail could be sumatriptan or any of similar medicines, naproxen or ibuprofen or naproxen, ibuprofen or aspirin, metoclopramide, and a cup of tea or coffee. Now there are 4 things, and that combination can also work, depending how severe migraine is. Remember, there are a variety of patients. Not everybody has to do this, but there are some patients. I would say if you're thinking about, if you're frequenting emergency room because of migraine, then consider talking to your doctor about this combination of medicines and use that at home. Hydrate yourself well before you do that, and do that at home so that you could avoid frustrations and visit to emergency room, which are also really very expensive. Now that was the treatment of migraine when you do have migraine. Now what about things that could control migraine? Now the first, whatever I talked about, is good. If you have maybe 2-3 migraines, a few migraines a month, that's all what you need, a medicine to counter migraine. Because of the nature of this condition, having migraine switch, we have no way to completely eliminate it. We can just turn it off. But sometimes this switch is so touchy, it keeps on coming. It keeps on turning itself on. What if you have 2 or 3 or more migraine a week, and each migraine lasts for many hours, a whole day, or many days? By the way, migraine pain can last days. Then it's frustrating, debilitating. It affects your quality of life, your social life, your work life, your personal life. It creates really further complications, anxiety, depression, and even forgetfulness. So that is not good either. So then you need to consider other options. Those are the patients especially who come and see neurologists, especially those patients who have more frequent headaches. Now they are seeing neurologists. But like I told you, neurologists are not available everywhere. Even in our place where there are so many neurologists, people can't see a neurologist all the time. So that's why it is good to know, so that you could discuss with your doctor. So what are those medicines? Those medicines were discovered by chance, meaning there were some medicines we were using in patients for other conditions, and some of those patients happened to have migraine, and they came back, then the migraines were better. So that's how we figured out it really. Until recently, then we have started to make some designer medicines, but previously all preventive or controlling medicines were discovered incidentally. In this discussion, I am talking about adult patients. I would make a separate video for children with migraine, so I won't go there today. So for adults, there are generally 4 or 5 categories of medicines, and patients who have migraine, they get used to it, they know these names. So I would just name them. The first class of medicine is what we call beta blockers. Second is calcium channel blockers, and then anti-epileptics, meaning those medicines which we use for seizures, antidepressants, or ACE inhibitors, or the other blood pressure medicines. All these classes of medicines were discovered, just I told you. For example, beta blockers and calcium channel blockers and ACE inhibitors, they happen to be blood pressure medicines. But not every blood pressure medicine works for migraine. Some of them do work. So beta blocker, I would just provide some names so that you are aware of that. Propranolol, metoprolol, netilol, timolol, these are the one ending with lol. They are beta blockers. Calcium channel blocker really for us is verapamil. In some other countries there is another one, flunarizine. It's not available in the U.S., but might be in some other places. In terms of anti-epileptics or anti-seizure medicines, topiramate or Topamax, Depakote or divalproic acid, gabapentin I would also include in that. In ACE inhibitors, lisinopril or candesartan, these medicines, these are common categories. And antidepressants, for example, in antidepressants, then there are further two classes. One is tricyclics, which is amitriptyline, nortriptyline, and the other one is SSRIs like venlafaxine and citalopram and fluoxetine, SSRIs. All these medicines we have reasonable experience and evidence that they could help with migraine control, meaning none of them are really pain medicine, meaning if you have a migraine pain, taking these medicines would not help. The purpose of these medicine is to go in and turn the switch off in those patients where the switch turns on every now and then. So that's the purpose. So that's why these medicines, if they are prescribed, they have to be taken every day. That's the catch. They have to be taken not just when you have a pain, every day. Obviously, when you're taking this and you have pain, you can also take the previous one I discussed. But they are taken separately every day to control frequent migraines. How do we pick up which of these preventive medicine to prescribe? Again, we are not there yet. We do not know which one of these preventive medicine would work best for an individual patient. Again, that knowledge might come in a couple of decades, in my opinion, or maybe earlier. But how do we do that now? Well, it's a kind of intelligent decision, if I could call that. Because some of them are blood pressure medicine. So if my patient has high blood pressure, I would pick up one of those because that would help in two different ways. Or if my patient has low blood pressure, I would not pick up this class. So that's how we figure out. Also, for example, if my patient has migraine and also has either anxiety or depression, then picking up an antidepressant or anti-anxiety medicine makes sense because that would help in two different ways. If my patient is obese, then giving topiramate makes sense because topiramate has a side effect of weight loss, but also only in high doses, not in small doses. On the other hand, if my patient is obese, I would avoid giving Depakote because that sometimes can lead to weight gain. So that's how we make the decision. But what happens in many patients that they don't have any obvious contraindications, we try one by one. Generally speaking, I would say we are able to find a medicine that could work for about 80% of patients. That's a number I'm giving you based upon my own experience for the last couple of decades. There are about 20% of patients where none of this approach works, and we'll go what we do for those patients. We'll talk about it, but any one of this could work. And each one of those medicines require their own discussion, and I don't want to go there, but what I'm just saying that all these options are available to you. For those patients who have frequent migraine, you have to talk to your primary care doctor either. And if you tell them that you are aware of that, you have done your research and all that, and you're aware of the risks, then your primary care would be more comfortable to talk to you and prescribe these medicines. Because if you show sign of uncomfortableness, then you would get a referral to neurologist if, by the way, neurologist is available in your area, easily available. And even in terms of neurology, I have noted that not all neurologists are comfortable treating migraine. There are variations, obviously, in neurology. I am being general neurologist, and here I would just briefly say that neurology is quite a complicated field. There are more than 15 subspecialty of neurology. So for example, headache itself is a subspecialty, meaning they are neurologists and then they are neurologists on top of them. They have more training in one field, for example, headache. Obviously, A neurologist who has subspecialized in headache is a much better headache practitioners than I am, but they are exceedingly rare. Not very, very few patients need to go and see a headache specialist of that kind. Most don't even need to see a neurologist. Now, in terms of what we do for those patients, I said about 20% or maybe less number of patients where none of this approach works, then what do we do for them? Sometimes we use Botox. In my experience, let's look at Botox. What Botox is an agent that temporarily paralyzes muscles. It's injected in muscles. So it is, for migraine, it's injected all around the head. Some here, some in the back, some in the shoulder area. All those muscles might get tense. In terms of efficacy, again, 1 to 5, talking about preventive medicines, I would say Botox is about maybe 3. It's not extremely effective. But again, it is only used for patients where everything else or rest of the things have failed. Only select patient population. We don't do it for all migraine patients for obvious reason. It's intervention. It's so many injections. It's very expensive. So it has to be done by somebody who knows. I do it, and our office has been doing it, Botox treatment, but it is not for everyone. In my experience, it works better in those patients who have chronic stress and anxiety associated with migraine. Because in those patients, these muscles, they get very tense and stretched, and giving Botox help. But in those patients where it is purely migraine, meaning the cause of migraine is just the switch inside, in my experience, Botox doesn't really work well. And so we use it sometimes. After that, there is a recent addition to armamentarium or ammunition against migraine of a class of medicine we call CGRP inhibitors. Just remember that CGRP inhibitors, you can Google it and read about it if you want to know more about it. But basically what it is, this is now real designer medicine. This is also new class of medicine we call biological agents. See, the previous medicines we talked about were chemical agents. They use chemical formulas. This CGRP inhibitors are biological agents. They are in fact monoclonal antibodies targeted to a specific mechanism. And right now, in the last few months, 3 of them have arrived. Their names, they always end with the letters MAB. Arunamab, Farmunazab, and Galcanazab. As you can see, I'm having difficulty even pronouncing them. I don't know how they pick up these things, but bottom line is, I didn't give you the brand names. The brand names available in US are Aimovig, Ajovy, and Emaglutide. They are recent addition, and more medicines of similar nature are coming. And it is also possible that targeting same mechanism, some chemical agents are coming. But these are recent additions. They are monthly skin injections. In terms of efficacy, I would say compared to previous interventions for migraine prevention, I say obviously these are new, my experience is recent, and comparative studies are not available, so I'm just going to give you ballpark figure during last 6 to 8 months when I've been using them. In terms of efficacy, they're about maybe 3 to 4, but that is another limb available to us, another area available to us, especially for those patients where everything else has failed. The good thing about this type of medicine so far, that the risk profile is good. They don't have any systemic, they don't have too much systemic side effects like many other preventive medicines. Obviously, you need a skin injection. The treatment is only once a month. If it works well. But what might be the long-term effect of that, we do not know yet. In terms of the trial data that was done before their approval and after trial experience, so far I am not aware of any significant issues with these medicines. In terms of fiscal issues, these are expensive medicines. Each injection is about $700 a piece, and insurance coverage is limited at this point. But somebody who has migraine, other things have not worked and can afford it, it is one of the options you can discuss with your doctor or your neurologist. Now, that I think is all what I wanted to talk about treatment. Now, one more time, if we could look back at what I talked about migraine being the most common type of headache, and out of that, migraine without aura being the most common. Some patients have auras. I described that aura. And then talking about, I didn't actually touch how do we diagnose migraine. Diagnosing migraine is relatively straightforward and simple procedure. There is really no test for migraine, no test available to us in clinical setting, and really test is not needed. For example, look at this way. If somebody is having a headache, and then that headache goes away, and a few days later headache comes, and then it goes away, and headache comes back and goes away, logically speaking, that is migraine. He or she might not have other symptoms with it, but most commonly that is migraine. Other things, what patients worry about? Patients worry about tumor or aneurysm. Logically speaking, if you think about it, or infection, if those are the causes of your headache would come and would not go away, and it would only get worse and worse and worse and worse, and then you have to, of course, seek medical attention. As far as aneurysms are concerned, aneurysms cause headache only when they bleed. And when they bleed, headache is usually devastating, and right away patients need medical attention, and usually their headache is worst headache of their life. If you have sudden worst headache of your life, then you should seek medical attention right away, go to emergency room. So who are the patients who, out of all this, the patients who are listening to this, who are the ones who need to really seek medical attention right away or see a neurologist? Worst headache of your life, especially if suddenly appearing, especially in those settings when you are like exerting, maybe. So the good example of that could be like passing bowel and forcing yourself, or having an orgasm, for example. At that time, if suddenly a headache appears, that needs medical attention right away. But at the same time, be aware that they are just simple, benign, very common headaches that happens around orgasm. That's a totally different thing. But if you have a sudden headache and there are other things associated with it, you're nauseous, you're throwing up, your arm or leg is weak, obviously, seek medical attention right away. Call 911. In fact, instead of calling your doctor, call 911, go to emergency room right away. Other than that, if your headaches also include something that is not known to happen with migraine, let's say you have a headache and then you also have a seizure-like episode, well, that is a different thing. Migraine is not known to cause seizure. So then you should go and see a doctor and try to find out what the cause might be. There might be different cause. Also, if you have a headache that is just not going away and it's just day after day after day and things are getting worse, obviously you need to see a doctor. I hope this information session was useful to you. My purpose was to educate you about headaches and especially migraine. I would, obviously this video was quite long, but the subject is big, and and if it was useful, then use that information and figure out a way to manage your headache. Be a partner with your doctor and help him or her out to figure out a way to manage your headache. At the end, I leave you with greeting of, again, peace and happiness and good health. Thank you. Thank you for listening.